Professor Tabernero, you are a member of the Clinical Advisory Board at Scandion. I thought we could begin by an introduction of your background and speciality.
Thank you very much. I'm Josep Tabernero, a medical oncologist by training. I'm professor of medicine and head of the medical oncology department at the Vall d'Hebron University Hospital in Barcelona, and also the director of the Vall d'Hebron Institute of Oncology, that is a research institute that covers all cancer research in this institution. I have been a member of the executive board of the European Society for Medical Oncology, ESMO, and have served as the ESMO president for the term between 2018 and 2019. Moreover, I have been appointed as a member of several educational and scientific committees, not only from ESMO, but also from the American Society for Clinical Oncology, the American Association for Cancer Research, and other professional societies related to the field of cancer. My special focus have been treating patients with gastrointestinal malignancies, in particular colorectal cancer, and also in the creation of the phase 1 unit, the early drug development unit at our institution, that is one of the largest in Europe.
Colorectal cancer being one of your specialties, could you tell us a little bit more about the condition and the greatest challenges in treating patients?
Sure. First of all, colorectal cancer actually it's a very frequent disease. Depending on the countries, it ranges between the first position and the second position, and mainly because it affects both men and women. So anything that we do actually to increase the survival in this population of patients, especially in those that have advanced or metastatic disease, is really very important in terms of numbers, but also in terms of societal needs. It's very important to mention that metastatic colorectal cancer continues to be an unmet clinical need for the management of these patients. Right now, actually, we have well-established up to 4th lines of therapy for metastatic disease, combination of different chemotherapy schedules, FOLFOX with oxaliplatin, FOLFIRI with irinotecan, a number of targeted agents, either related to inhibit the angiogenesis process, like bevacizumab, aflibercept, and even ramucirumab in some countries, but also targeting the epidermal growth factor receptor, like, for example, cetuximab or panitumumab. Also, we have drugs for the more refractory setting, like the combination of trifluridine tipiracil plus bevacizumab, well established in the 3rd-line setting, and also very recently fruquintinib, a small molecule that inhibits angiogenesis as well, and that has been recently approved for the 4th-line setting. But as you can see, we have several lines, but still patients, even they respond to these therapeutics. At some time point, they progress under therapy. And the reason for that is because drug resistance appears at some time point. And this is really a major problem that we have with all these cytotoxic drugs and biological agents. So it's very important that we work on that. And actually, one area of improvement is to revert as much as possible drug resistance when it appears. So we need to improve, several areas of treating patients with metastatic colorectal cancer. And one area, as mentioned, is trying to revert drug resistance.
Is that the challenge that the lead candidate SCO-101 from Scandion seeks to address?
Exactly. So SCO-101 is a well-designed drug that actually targets 2 different enzymes. The first one is what we call an efflux pump. This is a kind of enzyme that tries to excrete any kind of drug, in this case, a cytotoxic agent like irinotecan, outside from the cell. And what we do see in cancer patients is that this efflux pump called ABCG it's very often unregulated in patients with colorectal cancer, specifically in those that have resistance to some drugs, including irinotecan. What actually happens with this is that this upregulation of this enzyme, ABCG, causes a lower level of chemotherapy inside the cancer cells. And therefore, the chemotherapy drug works inefficiently to kill the cancer cells. So by targeting these efflux PAM enzymes like ABCG2, in this case with this compound, SCO-101, the chemotherapy drug, in this case irinotecan, will accumulate in the resistant cancer cells and ultimately kill the cells. This is the first mechanism of action of SCO-101. The second one actually is targeting one of the multiple metabolic degradator enzymes for irinotecan or SN38, that is the active drug of irinotecan. So these drugs, irinotecan and SN38, are degraded through a glucuronidization process. And in this process, one enzyme that is present in the liver is very key. This is 1GT1A1. Actually, this enzyme 1GT1A1 inactivate SN38, and therefore, if we have a drug like SCO-101 that is able to inhibit in part 1GT1A1, this may also cause an increase of chemotherapy, both in the liver and in the circulation, which actually will lead to an increased exposure of the cancer cells from the outside. So just to sum up, SCO-1 is a well-designed drug that by dual targeting of ABCG2 and UGT1A1 is able to increase the levels of both internal and external irinotecan exposure to the cancer cells, and thereby hopefully killing more cancer cells.
And recently we actually got data from the part 3 of the CORIST phase 2A trial. Could you give us your view on the result of this data and why it's important?
Yeah, actually we have data from different CORIST studies because CORIST part 3 is the more recent one. But actually I would like also to mention that we have CORIST 1 and CORIST 2 or part 1 and part 2 that actually were critical studies to define the recommended phase 2 dose for SCO-101 in combination with chemotherapy, in this case FOLFIRI, but also studying very preliminary the efficacy in patients that were refractory to several lines of treatment, including irinotecan-based chemotherapy. But coming back to the question that you did, focusing more on CORIST part 3, actually this was a very important study because in this study, the dosing schedule was redefined based on the previous pharmacokinetic data observed in CORIST part 1 and part 2. So two new schedules were designed, one with a 6-day administration and another with a 4-day administration of SCO-101. So basically, this was important in order to define which was the best strategy to treat patients with refractory metastatic colorectal cancer. More importantly, early signs of efficacy were seen in this study. So, for example, in the cohort with the highest SCO-101 dose, that was 250 milligrams, in 6 patients, actually 2 partial responses were observed. And this is really very important. It's a biological proof of concept that SCO-1 is working in the way that we expected. So SCO-1 was able to reverse secondary resistance to previous administration of irinotecan-based chemotherapy. Moreover, if we look at the whole population that was included in part 3 of the CORIST study, the efficacy data was encouraging in a way that we observed a median progression-free survival of 3.8 months and an interim, because it's very preliminary, median overall survival of almost 8 months. But actually, this is really very important compared to historical controls. Also, we are working extensively on trying to evaluate whether there is any predictive biomarker that could even help more to define which are the patients that may benefit more from the administration of SCO-101 in combination with irinotecan-based chemotherapy. So we are looking at the importance of the different variants, genetic variants of one of the target enzymes, UGT1A1, for example, and this is work in progress, but actually I think that this is going to be probably provide important information to redefine a little bit more the population, and also other biomarkers that we are very actively evaluating. But perhaps to sum up, I would say that the data that we have from the CORIST studies, part 1, part 2, and part 3, have demonstrated the proof of biological activity, the proof of concept that SCO-101 is able to revert acquired resistance to irinotecan-based chemotherapy.
And what does that mean for future development of SCO-101, but also the CORIST study?
Of course, we need first an initial demonstration that we have an active drug with a recommended dose, and that it's able to prove the concept for what it was created, right? This is what we had with the previous studies of CORIST. Now, we are in the process of consecuting a randomized phase 2b study. Of course, we have always to demonstrate that this regimen, irinotecan-based chemotherapy in combination with SCO-101, is able to be superior to what we consider the standard of care. And this is the need for a randomization. So the randomized phase 2b study will be exploring at the same time several parameters, such number of patients, randomization, endpoints, and this has to be still discussed with external experts. Of course, this is going to be the first demonstration consistently showing that there is a superiority in efficacy. Later on, I think that the company probably will discuss whether they think that the data is good enough to move to earlier lines of therapy. So even in patients that are irinotecan naive. But first, we have to demonstrate in a randomized fashion that the combination of irinotecan-based chemotherapy plus SCO-101 is better than what is considered the standard of care.
I thought we could end by you giving us your final thought on this candidate being a combination therapy to chemo.
Absolutely. I think that with SCO-101, we have seen that we have a very promising drug candidate that can be safely administered in combination with irinotecan-based chemotherapy, that works as it was expected by this innovative dual targeting, and therefore be a first-in-class kind of drug that it's able to reverse secondary resistance to irinotecan-based chemotherapy. And of course, it addresses a very important clinical problem with a huge medical need.
Thank you very much, Josep Tabernero.
Thank you. It was my pleasure.